Cancer Action's webinar, The Case for Universal Healthcare. Thanks so much for joining us today. My name is Leslie Riddle, and I'm the Program Officer at Breast Cancer Action. Joining me on the webinar today will be Wendi Dennis, Breast Cancer Action member and blogger at the Cancer Curmudgeon, and Diljeet Singh, gynecologic oncologist with the Mid-Atlantic Permanente Medical Group and national board member of Physicians for a National Health Program. Before we get started, I have just a few quick announcements. Breast Cancer Action doesn't take money from any corporations that profit from or contribute to the breast cancer epidemic. Our work is largely supported by individual donors like you. Please consider making a $25 donation today to support work like these educational webinars. Our presentation today will last about 30 minutes. At any time during the webinar, you can ask a question by typing it into the question bar on your right-hand side. We'll save time at the end to answer as many questions as we can. We want you to get involved with Breast Cancer Action. This webinar is a great way to do that. Please stay tuned for other ways we'll mention later on in the webinar. So I'll start by just running through the agenda for today's webinar. Wendy's going to start us off by talking a little bit about her experience as a breast cancer patient accessing healthcare both before and after the Affordable Care Act was implemented. She'll also talk about the current threats to healthcare and the culture of blame that people with cancer often face, and will pose the important question, who deserves healthcare? Dr. Singh will provide some of the nuts and bolts of the ACA, including its benefits and limitations, and briefly discuss the current proposals for healthcare reform that would serve to repeal and replace the ACA. She'll provide an overview of U.S. health indicators, rates of uninsured, and some problems with our for-profit healthcare system. And then she'll wrap up with some insights on how universal healthcare is the best solution, including some information on HR 676, the Expanded and Improved Medicare for All Act. So I want to take a little time just to talk about Breast Cancer Action. We were founded in 1990 by a group of women living with breast cancer who were frustrated with the lack of information about the disease. They founded Breast Cancer Action because they saw a need for a grassroots organization with a unique understanding of the political, economic, and social context of breast cancer. Our founders, only one of whom is still alive today, knew that their private medical crises were part of a larger public health emergency, and that the experiences of those dealing with breast cancer needed to be heard in order to address the crisis. Breast Cancer Action is the only organization that addresses the breast cancer epidemic at the intersection of breast cancer, the environment, social justice, and feminism. Our mission is to achieve health justice for all women at risk of and living with breast cancer. So I'd like to take a moment to talk about the core values that guide all of the work that we do here at Breast Cancer Action. We believe that health justice is a human right. We believe in honesty, fearlessness, and truth-telling about the breast cancer epidemic. And we believe in honoring women's diverse voices and lived experiences. We believe in putting people's health and well-being over corporate profits, and in transparency and accountability for ourselves and for others. We also believe in collective action that changes the world for the better. And last, we have integrity and freedom from conflict of interest. And I mentioned our focus on social justice. That's because we recognize here at Breast Cancer Action how issues of health and social justice are so deeply intertwined. And that's why we made a clear commitment to social justice as a foundation for all of our work around ending the breast cancer epidemic. And I want to talk just briefly about what that means to us as an organization. So the first is that we know that the breast cancer epidemic impacts communities unequally and leads to unacceptable differences in who develops breast cancer, when it develops, who gets high quality and timely treatment, and who dies from breast cancer. We also know that in order to address and end the breast cancer epidemic, we must tackle the root causes of these health inequities, which are often the result of a complex interplay of culture, power, economics, racism, and sexism. We also believe that no single injustice can be effectively addressed in isolation, and we recognize that injustices in our society reinforce each other in many ways and at many levels. And last but not least, in our work for health justice, we strive to be an ally by using the power and privilege we hold as an organization to build solidarity with communities who currently or traditionally have had less access to power, information, and resources. So that's a lot about the values underlying what we do here at Breast Cancer Action, but I want to talk just a bit about some of the specific issues that we work on. As the watchdog for the breast cancer movement, we educate, organize, and take action for systemic change in 3 distinct areas. The first is our work on breast cancer screening, diagnosis, and treatment, which examines the data from a patient perspective and includes breast cancer screening, healthcare access, drug and device approval, and demands more effective, less costly, and less toxic treatments. The next is our work around root causes of breast cancer, which focus on eliminating the involuntary exposures to hazardous and toxic chemicals present in all of our daily lives that put us at increased risk of breast cancer. And the last is pink ribbon marketing and culture, which often exploits a disease that devastates communities, misrepresents who is affected by breast cancer, and excludes and marginalizes women's diverse lived experiences of the disease. We address the true impacts that breast cancer has on women's lives and their communities. So I want to thank you all for taking the time to join us today and to learn a little bit more about Breast Cancer Action. We'll go ahead and get started with our presentations. The first speaker that we have today is Wendy Dennis. Before I hand it over to her, I just want to tell you a little bit more about her. Wendy was diagnosed with stage 3 hormone receptor negative, HER2 positive breast cancer in 2010. And that was just a few days before she turned 39. After years of working in both the for-profit and nonprofit worlds, and a mere month after her final Herceptin infusion, she turned a hobby of pet sitting into a new career path. She has since become a home health aide and also provides medical billing services for a mental health professional. A jaded view of America's broken health system and the exhaustion of living in the gig economy, which she'll explain in more detail, led Wendy to create the blog called Another One with Cancer in 2012, where she calls herself the Cancer Curmudgeon and tells the ugly truth about breast cancer. In October of 2016, Wendy participated in starting the #BreastCancerRealityCheck Twitter storm, which she and her friends hope will become the hashtag to fight pink ribbon culture every October. Thanks so much for joining us, Wendy.
Hi, everybody. Thanks for that introduction. All that is quite true. This is a story of being in the move to the gig economy. I had insurance in my previous jobs, and I went into a high-risk pool right after I finished treatment. I didn't even know that it existed, and this is in the state of Maryland, which is where I am from and where I live. I was trying to get insurance through e-insurance, and it was somebody who was on e-insurance who told me about MHIP, which is the high-risk pool for Maryland. And I was great. I had coverage, except for it costs $400, actually over $400 per month. So it wiped out my savings. So I was very happy when the ACA was rolled out in 2014, or was it 2013, to take effect in 2014. It was great. I was able to finally get coverage. The reason why I wanted to strike out on my own, or I guess I should talk a little bit about the gig economy, which is, as a pet sitter, I take on jobs for however long that job would last. If somebody's out of town, then I stay in their home and I take care of their pet. So my life is kind of like a jigsaw puzzle where I'm constantly, putting together, when dates that people are away. That allows me to work as much as I want, or as little as I want. Obviously, I want to work as much as I want because, the more gigs you have, the more money you have. But in the beginning, I, took it easy because, as anyone knows, if you're dealing with post-treatment, you're dealing also with some fatigue and a couple of other things. So that kind of control is quite essential. But anybody who also knows a little bit about the gig economy knows that it celebrates work, almost working yourself to death, sort of like an overworking thing in order for you to make any kind of money. Leslie, are we on slide 10, the ACA Roll Out?
Yep, you're good to go.
Yep. Actually, the next slide. A lot of rumors or a lot of stuff was going on when the ACA was rolled out, and if anybody was paying attention to any of the coverage, everybody knows that the website crashed and all this stuff. Maryland actually did their own, and their rollout was actually worse. It took a long time to get enrolled, but I don't care. I got coverage, so that was all that it means to me. I got coverage for less, and at least I'm not in debt right now, because I'm not paying $400 to $450 per month. So now that the political situation has taken the turn that it has, things are a little bit different. The ACA is being repealed. Leslie, the next slide. What will happen to me? I don't know. I guess we're all kind of guessing what's going to happen. My best guess, living in Maryland and monitoring the political situation and listening to my representatives, is that they will reinstate the high-risk pool for those of us with pre-existing conditions. The government here loves that, but I can't afford that. So I've already made some decisions. Why bother with mammograms? And I'm almost finished with my yearly oncology visits anyway. I'm approaching my 10-year mark in a couple of years, so I just won't go anymore. I already try to avoid going to the doctor as much as possible, unless I absolutely have to, just because I'm not a fan of going to the doctor. As far as getting cancer again, monitoring it, and hoping I don't get cancer again, I'll cross my fingers. I don't know what I'm going to do about my allergy medicine. Okay, Leslie, next slide. Now, personally, I think high-risk pools are discriminatory. I think it's part of the blame. And just listening to some of the rhetoric that's been going on with various senators out there, members of Congress, some of the things that they said, I believe Pat Toomey in Pennsylvania compared people with pre-existing conditions to houses that were burning down. To me, that's an element of blame. And I've written before. Anyone who's read my blog knows that I kind of complain quite a bit about those "did you" questions. It's people always want to ask you, well, did you do this? Did you do that? They want to know if you did something that maybe they're doing that they can prevent getting cancer. It's their get out of cancer free card or whatever. It all kind of gets down to that thing that I call, cancer is your fault. Why didn't you eat more kale, eat blueberries, run a couple of marathons, when actually, one of the highest risk factors for having cancer for a woman is being a woman, aging, or if you're like me, you have lots of family history. But when people want to turn this into policy, suddenly they want to place blame on people's individual actions and individual responsibility. Next slide. So who deserves health care? One of the defining, identities of America is, pulling yourself up by your bootstraps. I mean, it's definitely an argument that I see, when we talk about the welfare state and people who accept any kind of government assistance, they don't deserve anything. They don't deserve microwave ovens or refrigerators or anything like that. And nothing was more apparent was when Jason Chaffetz, I believe it was, said that people should not buy that iPhone, which is completely out of touch. How many iPhones would you have to give up? I think the number is something like 200 just to afford health insurance. So it's a little insane, and it's just sort of to compare health care or health insurance to an iPhone. It's on the level in my mind with that welfare queen myth that we still have and worship here in America. Leslie, next slide. The other aspect of this is that we can't shop for neither healthcare nor insurance plans like any other product. It's not like going out to buy a car. There's not a lot of ways you can compare, and if you live in a rural area like I do, your selections are quite limited. There's one hospital in my town. There's one half an hour away, which is a little bit bigger and better. I was treated at one that serves a very large radius, and just simply because it's a rural area. So that free market idea doesn't really apply here. I can't compare cost. And then on the other hand, on the other side of that is, it's kind of hard to compare and shop if you're unconscious, like say you're in an accident or something like that. You can't just go to the hospital and expect that the nearest hospital is covered in your insurance plan, or that all the doctors or all the phlebotomy labs, any of that stuff is also included in an insurance plan. We all know about those stories about people who get these outrageous bills after they go to the hospital, and it's because they were treated by somebody who wasn't in their network. Next slide, Leslie. I think I've made my opinions pretty clear. Prior to last November, I attempted to keep my left-leaning thoughts off my blog and my Facebook page and stuff like that. But at this point, the personal has become political. There's nothing I can do about that. That's I feel very threatened in terms of my life and my access to being able to pay for healthcare. I've kind of I don't want to say abandoned my blog, but I've neglected my blog because I've spent a lot more time volunteering for my local Indivisible chapter. Those of you who don't know what Indivisible is, it's that Google document that went around the internet shortly after the election, made up by congressional staffers during the Obama administration, telling people to act sort of like the Tea Party acted back in 2009. So yeah, I kind of belong to that group of people who are shouting at absent members of Congress at town halls. Next slide. I have a hard time with slogans anyway, and I also acknowledge that there are a lot of problems with the Affordable Care Act. I understand that it was financially or economically impossible for some people in a particular economic bracket. So I literally, on the Women's March, this picture is me at the Women's March in Ocean City, Maryland, because we had a local one in Ocean City, Maryland, and I made a sign that says "Fix the ACA" instead of the popular hashtag Save the ACA. I don't believe in throwing out the baby with the bathwater. I know a lot of people hate ACA, but there's ways to fix it. So let's do that instead of just totally gutting what's been going on. It's kind of funny because now I find myself advocating to sort of protect insurance companies when I know that they're a bit of a problem. And I'm speaking to this as someone who also, not as just a patient, but as a medical biller. Right now, in fact, I'm trying to find out why one of the patients for my client, the insurance company, just stopped paying for her treatment. No reason was given on the EOB. So I have to grapple with them, and it's going to take forever to find out why they stopped instead of them just telling me why they stopped paying, and then to find out how I can fix the problem. So I have no love for the insurance companies, but on the other hand, without them, I wouldn't afford healthcare, and a lot of other people wouldn't afford it either. So the system is totally broken, and we need to fix it. Which leads me to the final thing, that we need universal health care. Why are we fighting it? Almost every person that I talk to, particularly in the medical field, and even conservative pundits like George Will, they see it as inevitable. If it's inevitable, then let's go ahead and do it now instead of resisting. And that's my story. Thank you very much.
Thank you so much, Wendy. So appreciative that you could join us today and share a little bit about your story and your situation. We're definitely going to want to have time for people to ask questions for you, but we'll save those to the end. I'm going to go ahead and bring Dr. Singh up for her presentation. And again, I want to kind of give you some background on her before she launches in. Dr. Diljeet Singh is a gynecologic oncologist with the Mid-Atlantic Permanente Medical Group in Washington, D.C. She recently relocated from Phoenix, Arizona, where she was the Program Director of Gynecologic Oncology and the Program Director of Cancer Prevention and Integrative Medicine at the Banner MD Anderson Cancer Center in Gilbert, Arizona. Dr. Singh received her medical degree from Northwestern University and a master's degree from the Harvard School of Public Health. She also completed an obstetrics and gynecology residency at Johns Hopkins and a gynecologic oncology fellowship at the MD Anderson Cancer Center. She completed her doctoral degree in public health on cost analysis at the University of Texas School of Public Health and an associate fellowship in integrative medicine at the University of Arizona. And she currently serves as a national board member with the Physicians for National Health program. They are a nonprofit research and education organization of approximately 20,000 physicians, med students, and health professionals who support single-payer national health insurance. So thanks so much for joining us, Dr. Singh.
Thanks so much for having me. I'm just looking for my slides. Are going to pop them up?
Yep, I'm queuing them up right now.
Perfect. Great. Now I have control.
You're all
Sorry, you guys, for my technological weaknesses. It looks like I don't have control.
All right. Give me just a sec.
So while Leslie's doing that, just you guys heard about my background. Now I focus on surgery. I gave chemo in the past, but here for Kaiser in the Mid-Atlantic, I take care of women with ovarian, endometrial, cervical, vulvar, and vaginal cancers. I've been involved with Physicians for a National Health program since I was a med student back in the late 80s, and have been a board member for about 9 years now, or involved in some ways. I'm now a board advisor. So Physicians for a National Health Plan, as you guys heard. Hey, so Leslie, I'm sorry to interrupt you all. I still don't have control. Do you want to just move my slides for me?
Yeah, I'm happy to do that. I'm not sure. Looks like I've handed them over, but if there's any trouble, I can go ahead and do that.
Yeah, I can't do it. So if you could do the next slide, that'd be great.
Sure, no problem.
So just briefly, you know, I, as a believer that insurance companies don't add anything to healthcare, was not supportive of the ACA, but I do think that it helped some people to see our healthcare and how it's organized more clearly. I think we're finally sort of as a nation and as a culture starting to believe that it's reasonable to have access to healthcare. And as we started to look at specific provisions that are out there, it started to make, you know, why those provisions are there. If you looked at them from a health perspective, it makes no sense whatsoever that you wouldn't cover pre-existing conditions, right? That doesn't make health sense. People who have a condition need health care, right? You start to say, well, where did that come from? It became because the goal of the health insurance company is to make money, not to take care of people. And then, of course, thinking about the arbitrary things that haven't been covered by different plans, things like maternity care, access to contraception. And then, in some ways, I would say that the other weakness of the ACA was it didn't really control costs. Next slide. I had thought about trying to tell you guys, give you guys some guidance about what the current healthcare plans are that are out there. And unfortunately, it's impossible to do that. There's been so much flux. The bill, you know, that's in the House will likely change in the Senate. But I will say there's some clear consistencies. The number one goal of the current party is to decrease costs. And all the plans so far that have been put forward will increase the number of uninsured, will increase costs for people who are older, sicker, less wealthy, and who have prior conditions. And it'll increase politics and sort of decrease good health policy. And I say that in the sense that I think, oral contraceptives decrease the risk of ovarian cancer for 10% for every year you use them. They decrease the risk of endometrial cancer by 30% for 5 years of use. Why oral contraceptives are a political issue sort of doesn't make any sense. But again, it's sort of this issue of healthcare being about politics, not good health policy. Forever, being a female person automatically meant that you paid more for insurance, and it looks like that will likely be the case again. And then many basic needs, things like maternity care, prevention care, will no longer be covered. And that's one of the big, in quote, selling points of these plans is that they'll offer more choice, choice being inadequate coverage. Next slide. Can you give me the next slide? Thanks. So, there's a million ways to think about it. One of the ways I think about healthcare is just from a purely philosophical one, that it's not a business. Because in a business, the beneficiaries aren't the people who need healthcare. They're company executives, and then they're the people who invest in the company. And those companies have what's called a fiduciary responsibility to make money for their investors. So they're not actually driven by the patients. Many Americans, and in every survey that's been looked at, most Americans believe that healthcare, that everyone should have access to good care without financial hardship. Unfortunately, there's a lot of misinformation in this world. Our president, our prior president, President Obama, said, well, what do you mean there's not health care for everybody? Everybody can go to an emergency room. Next slide. Most of the world has accepted the concept that healthcare is a human right. And we're the only developed nation that doesn't provide comprehensive health care to all. Even when the ACA was enacted, it accepted the likelihood that a substantial number of Americans and American residents would remain uninsured. Currently, there's 31 million underinsured. And depending on the year and the estimate you read, somewhere between 28 and 33 million Americans are uninsured. One of the things we really don't talk about is the concept that people die every year from lack of coverage. Somewhere between 30 and 45,000 people die a year from lack of coverage. Like, lack of insurance should be a pre-existing condition, right? But I think that it would be amazing, for example, right, 40,000 women die of breast cancer. Will die of breast cancer in 2017. 31,000 will die of a gynecologic cancer. Those numbers are similar. Lack of coverage is a disease. Next slide. The other way that I think it makes sense to think about it, though, is purely the practical. Even if you don't philosophically think of it this way, the truth is the system that we have is unsustainable, and it puts an incredible burden on our economy and businesses large and small within our economy, increasing premiums, shrinking coverage. And the fact of the matter is, by a large amount, we have the most expensive healthcare system in the world. And next slide. If you look at both our private and public insurance plans, both of them put substantial burdens on economy. Back in 2005, and now they aren't willing to put the numbers out there anymore, General Motors put out the concept that $1,500 of each car came from the health cost coverage for its employees. If you think about the idea that in the rest of the world, car companies don't think about what's the best health care, or what's the least expensive. And unions don't spend all their time trying to figure out what kind of health coverage they can get for their members. Imagine how much could get done. Next slide. And the other interesting thing, about this is that it's not a secret and it's not a lefty thought process, right? The Wall Street Journal, Fortune magazine, MSN Money, these are not lefty organizations, but they all, when they look at it from a practical perspective of how do you fix this in our healthcare system, single payer and universal coverage make the most sense. Next slide. I'm going to give you a couple slides, and Leslie will make sure you guys have access to them on the website, just so you have numbers. But looking at average deductibles that are going up faster than inflation. Next slide. 1/3 of all bankruptcies in America are medical bankruptcies. That is, somebody went into bankruptcy because they owed for their health care. Of the people who went medically bankrupt, the vast majority of people had some kind of coverage when they became ill. And then they lost that coverage because of their illness, because they lost their job, because they weren't able to work. Next slide. And if you think of the other economic concept, medical debt is the most common ding on credit reports that prevents people from being able to buy a house or a car or whatever it is. Next slide. So what is it? Where is our money going? If we really are spending twice as much money as other developed countries, why is that? And what are we getting for it? So most of the data says that we don't get more care. Canadians see their doctors more, spend more time in the hospital. We clearly don't get better results. We do worse than most other developed countries on every measure you can think of. Life expectancy, infant mortality, immunization rates. In countries like Cuba that do not have the standard of living that we have, do much better than us. In addition, we don't cover everybody. So here we have a system that's expensive and inadequate. Next slide. Why is this? This is a slide showing that exact data, right? The average cost of $9,690. This is actually from 2014, but substantially greater than any other countries. Next slide. So where are we in life expectancy? We are less than Germany, the UK, Canada, Sweden, France, and Italy. Next slide. We see similar kind of things for infant mortality. We have the highest of the same list of countries. Next slide. And maternal mortality, the number of women who die during their peripartum time, around the time they're pregnant or delivery, is higher substantially again. Next slide. So is it because we just have bad health habits? We're older, we use too much care, and so errors happen to us? Next slide. No, it's not. We smoke less than many countries that do better than us. Next slide. We're younger than a lot of countries who do better than us. Next slide. We spend less time in the hospital. Next slide. We see doctors less. Next slide. So what's the problem? The problem is for-profit insurance companies. And again, they compete not by increasing their quality or by even decreasing their costs, but they do it by avoiding unprofitable patients and limiting services. If you think about that, it's just antithetical. It doesn't make any sense that the healthcare system is based on avoiding people who are sick. When we look at the administrative costs and when we look at profit for insurance companies, roughly 31% of every dollar, 31 cents of every dollar are a combination of administration and profit. So administration happens on both sides, right? We know that there's movies about insurance companies that hire people to decline coverage for things that are technically covered, right? That's an administrative cost for the insurance company. And then there's a flip side of it, the hospital or the clinic that employs people who have to deal with Aetna, United, Blue Cross Blue Shield, you know, you name it. When I worked at Northwestern before I joined Kaiser, I worked with 4 other G1 oncologists. And of the 5 of us, we had 5 G1 oncologists, 4 nurse practitioners, 5 chemotherapy nurses, and 10 people who did our billing. Next slide. This slide makes me sick. The growth in the number of physicians versus the number of managers since 1970 to 2015. I have a slide like this somewhere of nurses compared to administrators, and you can't even see the nurse line change on the bottom. Next slide. So these are different parts of the health industry: pharmaceuticals, insurance, medical supply, pharmacies, distributors, profit. That's all pure profit. That is not part of what they put in for research, et cetera, et cetera, et cetera. Next slide. I'm just going to read off these numbers just so we can try to get our mind around them. These are the salaries for the chief executive of United, 66 million. Cigna, 27 million, Aetna, 15 million. What does that even actually mean, right? And if you think about, as we hear about healthcare reform, the thing we hear over and over is that we don't have enough money. We don't have enough money to cover everybody. We don't have enough money to cover mental health services. We don't have enough money to cover preventive care. If we got back 30 cents of every dollar, good data shows that we could cover all the things we want. Next slide. If you compare profitability, so return on input, and even compare drug companies to the Fortune 500 median, it's astounding. Next slide. So what's the solution? I've sort of thrown the term single payer and universal health care around. Universal health care is the concept that everyone is covered. Single payer is the concept that we don't have insurance companies, we don't have a middleman, that there's one organization that distributes our healthcare dollars to multiple care providers. So it's simpler, it's more efficient. Theoretically, we would get back, of that 31%, we would get 28% back if we compare ourselves to Medicare, where the overhead costs are less than 3%. Because we would coordinate things, you know, we would think that whether you lived in a rural community or you were in a more urban setting, you would still have access to the things you needed. Next slide. There's lots of different single payer plans out there. Many states have single payer plans. And if you go to the Physicians for a National Health Plan website and the addresses at the end, you can look up your own state and see what the activity is there. But currently, this bill, HR 676, which has been circulated for many years now, is a national bill for single payer. Currently, there are 112 members of Congress who are co-sponsoring this. Next slide. And I think sort of having this kind of nitty-gritty of what does the bill want? It wants healthcare to be publicly financed but privately delivered. That means whatever clinic you go to, whatever hospital you go to, those aren't going to suddenly disappear and go away. physicians are not suddenly going to be all employed by the same person. We're not going to eliminate nurses unions. So publicly financed, privately delivered healthcare, and basically take the basic principle of Medicare, which needs to be improved, clearly needs to be improved, and then expand it to cover all U.S. residents. There would be choice in the doctors and hospitals you wanted to go to, and you would be guaranteed access to comprehensive, high-quality, affordable health care, regardless of employment, income, or health status. One of the hardest things about talking about this with people is that many people are healthy, and they don't think about when they're choosing healthcare, they don't think about what it would like to be sick. When I worked in Arizona, I met somebody who'd been a teacher for her entire 24-year career, since the time she was in her early 20s. And 2 years before her sister got diagnosed with breast cancer, she had switched to a health savings account with a really limited catastrophic coverage only that her school district offered to her. And then her sister got diagnosed with breast cancer. The sister was 5 years younger than her, and her sister got tested and was found that she had a genetic mutation that substantially increased her risk for breast cancer as well as ovarian cancer. So this woman was not able to get coverage for her testing. Back then it was more expensive than it is now. It's still pretty expensive. Back then it cost $3,000. Out of pocket, she's a teacher, her husband's a police officer, and they had used her side of the insurance because it was better, sad to say, two public servants. And she got tested for the mutation out of pocket. She was positive, and so she wanted surgery to decrease her risk of getting cancer. And she was willing to say, okay, that's fine. If you guys aren't going to cover mammograms, I'll just make the leap to mastectomy. And they refused coverage. And between letters and, testimonials, 3-year process, never got resolved. And at that point, of course, she had a pre-existing condition, the BRCA mutation, and she got diagnosed with breast cancer. That was completely preventable. Her story just points out in so many ways the issues with our healthcare system, right? It's fragmented, little pieces, everybody's different. Some clinics doing one thing, another hospital's doing another. They're competing. These insurance companies are competing not to provide the best quality care and not to decrease healthcare costs. They're competing to make the most money and to get the people that are going to cost them the least. If we took healthcare insurance companies, and we shouldn't even say healthcare insurance, it's just health insurance or insurance. If we took them out of the equation, we would save more than $500 billion a year, which would easily guarantee comprehensive healthcare with no copays, no deductibles, covering the basics again, preventive care, mental health, optical, dental. Next slide. You can go easily. There's a website, HR 676. You can find it on the congressional websites. The funding, the concept is to fund it through existing federal and state healthcare spending, a small payroll and income tax that's based on ability to pay. And a lot of these taxes would be offset because there'd be the lack of premiums and elimination of out-of-pocket costs, and people would get paid more because their companies wouldn't be taking part of their what would be salaries and putting them into these benefits. In addition, we could make smarter decisions about everything. How many MRI machines do we need? And how many nurses do we need to give flu shots, right? We could distribute the number of high-tech care things we need into the right settings. And these decisions wouldn't be made by people who are earning money based on it. They would be made, ideally not be made by people who are being paid by those organizations, but instead in the UK, in Canada, much of Europe, community elected officials, small community, not like presidents, but like mayors of towns, are the people who are involved in making decisions about building a new hospital, adding a new clinic, hiring a new specialist. Next slide. It doesn't have to be complicated, right? This is the, in quotation, software that was used when Medicare was implemented. Literally, do you want Medicare? Do you not want Medicare? Sign your name. Beautiful thing. Next slide. That's the website, and I'm sure between Wendy and I, they'll hopefully have some questions for us, and I think we have time to answer them.
Great. Thank you so much, Dr. Singh. Really appreciate you joining us today, and thanks to both of our panelists. I want to just pull up a slide that has some resources for you all that came up during the course of the presentation. Of course, we have Breast Cancer Action's vision for universal health care, which is on our website. I encourage you guys to check that out. We also have the websites for both the Cancer Curmudgeon blog, Wendy's blog, another one with cancer.com, as well as Physicians for a National Health Program, which is PNHP.org. So great. So we'll be opening up to your questions in just a minute. But before I do, I want to talk just a little bit more about how you can get involved with Breast Cancer Action if you're interested in doing so. You can become a member, signing up for our news action alert emails to keep up to date on all the issues we cover. You can join us on Facebook and Twitter to connect with others and help change the conversation about the breast cancer epidemic. And you can also donate to support our education and advocacy work. Lastly, you can help others get involved. Tell your friends, tell your coworkers, your family members about this webinar and how they can take action. And I want to mention that we do record all of our webinars and make them available on our website under the Educational Resources tab. So please feel free to share that. And I was also made aware that there were some issues with time lag with the slides appearing on your screen. I apologize for that. If you missed anything that was being discussed and you want to have an opportunity to look at those slides again, they'll be available on our website under our webinars tab. So I want to go ahead and open it up to any questions that you all have on this topic. And, you know, as we go, you can continue to type your questions into the box, and we'll try to get to as many as we can in the time we have left. So let's go on to the first one here. So there was a question about the number of healthcare providers who would be available if universal health care was implemented. Will there be enough doctors to cover everyone who needs care once everyone has access? Maybe Dr. Singh, I'll throw that to you.
Yep. The data has been looked at in a bunch of different ways. Part of the answer to that question is there's probably lots of things that doctors do that nurse practitioners could do that a whole bunch of other providers could do. And then there's been a real push within medicine in the last 5-7 years to train more primary care docs that a number of medical schools have invested in. So to answer the question, I would say yes. We're going to have to think hard about it, and I think that's the good news about thinking about a community deciding what they need. I'm a subspecialist, I do surgery, but the truth is we need less of me than we need of primary OBGYNs or family practice docs. The sad truth of the matter is I get paid a lot more. Now I take a lot more risk, I had longer education, but the way specialists versus primary care docs are paid has never made any sense. I actually think primary care docs are smarter because they have to think a lot more about things. I just need to know the stuff that I take care of. So there's a whole bunch of reasons we will have enough providers, and hopefully we'll have a more balanced provider pool. The vast majority of data, like if you look at countries that have had universal coverage and that made the switch, it was a relatively rapid uptake in providers and distribution of providers. And so the answer is yes. But I'd also like to see us do some good thinking about what our providers are in terms of training and, what are the things that non-physicians should be doing.
Great, thank you so much. We've had a question also come in specific to California, which, I think a lot of our members are based here in California. Any comment on SB 562? That's the single-payer Medicare for All health proposal in California. Economic analysis was released today. It can work. Insurers and other interest groups will lobby hard against it. And actually, that's a sentiment that's come up in a couple questions about the insurance lobby fighting this. What do you think? I guess I'm asking a two-part question. If you do have any thoughts on the California bill specifically, otherwise, what do you think would be a successful way to counteract these inevitable lobbying efforts?
I don't know specifics. My long-term recollection, just because I know a lot of people in the single-payer movement in California, is that the bill has a lot of similarities to 676, but I haven't certainly looked at the most recent economic analysis. There's two big single-payer physician for national health plan organizations within California, and I'm pretty sure they have their own website that you can link through towards the PNHP site, and you should be able to find good data there. There's also the staff who work for PNHP can always connect you with one of the board members from California. How do we deal with the power of lobbying from insurance companies and pharmaceuticals? I think the number one thing is education. I think that people don't get it. People don't understand that what it is to be sick until you're sick. There's that issue. And then the other part is that people don't understand where our money is going. I think that if you told everybody on the street, one person at a time, that they could get 30 cents of every dollar that they have back, which for most people means you would eliminate their car payment and their rent/mortgage, how much more money they would have. So I truly think it's educating individuals. And then the other part is we've made it too blue and red and Democrat, right, left. You can look at this from so many perspectives. If you really, truly support businesses in America, you would support single payer. If you really, truly thought that we need to be the most innovative, most free-thinking, most creative nation on the planet, then people shouldn't be worried about starting up their own company because then they won't have insurance, or that they can't have a pet sitting business like Wendy because they have breast cancer and they need X, Y, or Z, right? The limitations and the immobility in the job market because of this. I mean, I don't consider that a left or right issue. So I think we just need to talk about it. And I think the other part of it is that when people talk to me, often it's because they didn't have access to preventive care that they ultimately see me, not for everything, but certainly with like something like cervical cancer. they're apologetic. They're like, oh gosh, I lost my job and I didn't have insurance. And they're almost embarrassed. And I think that just has to change in our culture. That's ridiculous. We should all have access to healthcare just like we should to education, just like we should to clean water and air. So I think there's lots of things we need to do, but number one, I would try to take pure politics out of it and talk about it as an issue. And you have to talk and talk and talk and talk, because there's a lot of money. It's not just lobbyists, it's like gobs of money. You know, all that data, I have some other quotes that I can give to Leslie to put on the website that came from businesses supporting single payer. All of them backed off. They backed off because of their friends in the insurance company business and their friends in the pharmaceuticals, even if it would be better for them as a company. So that's a right-left, discussion that shouldn't be in play. So I don't know. I probably rambled a bit there on that. Got on my soapbox.
No worries.
That was helpful.
Sure. Thank you so much. Well, I think we'll have time for maybe one more question. I think this one kind of speaks to, how people stay motivated to work towards this universal healthcare vision, right? In this sort of political climate that you're talking about, people feel like a single-payer system feels further away than it ever has before. In some ways, as you're talking about these proposals, a lot of this is making sense, and yet where we are right now in this political landscape, it just feels difficult and challenging. So I would pose to both of you, and maybe have Wendy start, and both of you have, 30 seconds to answer. What keeps you motivated to working for universal health care, for your vision for universal health care?
What keeps me motivated is that it's right. That's the short answer. I think it's the right way to go. And also, obviously, I have a personal stake in it. So yeah, it's just what I do.
So I'll be truthful. I don't feel motivated every day, but on average, I can muster up the motivation. And why do I muster up the motivation? Because I think of myself, I think of my family, I think of my neighbors, and I think of the women I take care of and their families. And I think about the things that people go through when they should be focused on taking care of their health. Paperwork and the denials. And I agree with Wendy. It's right. And I actually, truthfully, do not think it's farther away. The idea that people are, starting to say, well, gosh, pre-existing condition, that's ridiculous, right? I think that's a step in the right direction. And that is a huge step. It was something before the ACA, we accepted it as a society, that insurance companies were allowed to do that. As we're having people potentially have their insurance taken away, I think we're waking people up to the idea that, you know what? That it was their right to have insurance. And I think that the other thing that's inspiring to me is that it's pretty simple, right? Congress people and lobbyists and people make it very complicated, and they don't want to do the math on this and talk in a complicated way about this. The truth is, give me back 30% of the dollars in this system, and I could cover everybody, and we could give them excellent care. That's inspiring to me.
Absolutely. Well, thank you so much. We're about out of time here, and so I want to go ahead and wrap up. I hope that everyone enjoyed today's webinar, and I just want to thank you so much for all your questions. If you think of one later that you'd like to ask, you can always follow up with us at info@bcaction.org. We'll try to help you through getting those answers. Dr. Singh, I don't know if I can, forward you some of the questions that we didn't get to today?
Yes,
and
please.
Could take a stab at them?
Absolutely.
We could get back to people. That would be great.
Yes.
In the interest of time. So again, I want to thank you all. I wanted to mention, as I did before, that Breast Cancer Action relies on your support to make these webinars possible. So if you have gotten anything out of today and felt inspired to take action, please do consider making a donation of $25 or more so we can continue our educational programs, including these webinars. And I want to give just a big final thank you to Wendy and Dr. Singh. Oops, looks like someone opened up the web page. That's us. But I want to give a big thank you to both of you and to all of you for your time and attention today. And thanks so much. Please watch your emails for a short survey we're going to send you. It'll enable you to provide some feedback on this webinar to help us make this program better and better. So thanks so much, and have a great rest of your day.
Thank you.
Thank you.
Thanks, guys.